Good afternoon. My name is Nick Tan. I'm a cardiology fellow at Mayo Clinic, Rochester, Minnesota. And today I have here with me Dr. Ian Kronish, who is Associate Professor of Medicine at Columbia University. And he's here to talk to us about the CODIACS Quality of Life trial. Thank you for being here with us.
My pleasure.
So I know that you just talked about the trial earlier in the afternoon, but why don't you share your thoughts about what the rationale of the trial is and what the results are?
Sure, thank you for the opportunity to come talk with you guys today. So the main reason for the CODIACS trial has to do with the fact that depression is a cardiotoxic risk factor. There's lots of epidemiologic data showing that patients who have depression after acute coronary syndrome are at twice the risk of having another cardiovascular event or mortality. They also have lower adherence to medications, higher healthcare costs, and lower quality of life. And so a lot of people are trying to figure out how can we really help this patient population. And so in 2008, the American Heart Association, in conjunction with some other societies like the American Psychiatric Association, released a scientific advisory recommending that all patients with acute coronary syndromes get screened for depression after ACS. And yet, there thus far had not been any trials formally assessing the effectiveness of depression screening. And there have been some critics who've thought that these recommendations are somewhat premature. Some of the reasons they cite for why we need to really formally test this guideline before putting it out there broadly is that the guidelines assume that depression treatments that have been found to be effective in depression treatment studies will be similarly effective in patients who are identified just through depression screening. But there's concerns that if you just identify patients through screening using this instrument, that you might not find patients who are really engaged or interested in treatment, and the treatments may not have the same effectiveness. There's also some concerns that not only does depression screening take limited resources that we always have, as a primary care provider, there's a million guidelines that people want us to follow, and we need to really think carefully about which ones are the highest priority. And then there may be harms from treatment, whether it be side effects from more prescribing antidepressants or labeling patients with a psychiatric illness. So there are reasons why screening may or may not be helpful, and that's why we wanted to do this trial. So I can tell you briefly about the trial and how we did it. We did this trial at 4 sites around the United States, Health Partners in Minneapolis. In New York City, it was Columbia Presbyterian. We also did it at Kaiser Northwest in Portland, and then the 4th site was at Duke Health System. And we had all these sites scan their electronic health records or insurance claims for patients who had an acute coronary syndrome were at least 2 months out from an acute coronary syndrome, and then someone proactively called them and screened them with a screening instrument called the PHQ-8, which a lot of people have heard of the PHQ-9, and the 8's very similar, except it doesn't ask about suicidality. And then patients who were screened either got offered enhanced depression treatment, which we provided by the study. That was sort of one group. The second group got screened, but were not offered treatment. We just sort of notified their doctors and left it at that. And then the third group didn't get any depression screening as well. So that was really our usual care group. The main findings of the study were, one, we identified a lower than expected rate of positive depression screens. Only 7 patients screened positive for depression when we screened in this manner. And then the other major finding is that when we looked across all 3 groups, there was no signal of any benefit in terms of overall population reducing depressive symptoms or improving quality of life. And so basically it was sort of a negative trial. Some of the caveats we want to make sure people walk away with are that, first of all, because it was a screening trial, and there's some debate around what really constitutes a screening trial, but we excluded patients that had a history of depression. And so these data don't apply to patients who already have depression and are probably at higher risk of either having a relapse or a worsening in the depressive symptoms in the context of an ACS. And we didn't talk about those patients in this trial. And the other caveat is the way we went about the depression screening. It was done by a centralized person who called someone on the phone. It wasn't done in the context of a patient-doctor visit you're having with one of your patients in Fellows Clinic. And so we don't want people to walk away with thinking that they shouldn't be thinking about or asking their patients, about if they're stressed or depressed after acute coronary syndrome. this was really about a sort of a population health perspective where you had a care manager proactively contacting patients. I sort of started off telling people that, at the beginning of the conversation today, that depression is clearly associated with increased risk. It clearly impacts patients in terms of their quality of life. And so we don't want to lose the focus on sort of trying to think about how do we deal with that problem. We're just commenting that sort of this more population health approach to sort of systematically screening people didn't really seem to be effective.
Thank you very much, Dr. Kronish, for sharing your thoughts on the trial and for conducting it in the first place. For more videos like this, please go to youtube.com/FITsOnTheGo.